So my mandate today is to talk about chemotherapy in metastatic gastric cancer, 2 versus 3 drugs, which to choose over another, and how to sequence. So I will stick to very specific things here. We've already heard about the problems of gastric cancer and how dismal the outcomes are. And this is again from CCO, which says that the first line treatment for advanced disease is generally selected on the patient age, the functional status, and some biomarker findings, especially talking about the HER2 overexpression. And frequently the chemotherapy consists of single, double, triplet regimes based on how fit your patient is. So this is just to show you that chemotherapy as compared to best supportive care has definitely helped many of our patients. And this is a Cochrane review which was published in 2010, telling you that the overall survival with the various regimes that were used during that period was 11 months as compared to 4.3 months for best supportive care. And you can see the p-value is a very significant one. So you can see that over 103 trials that were looked into here. Now, we need to again look into those patients who will benefit, how they will benefit, and for which we have these prognostic factors that are being taken into account. One of the most important for most cancers, including stomach cancers, the performance status, whether it's 2 or 3, the presence or absence of hepatic metastasis, peritoneal carcinomatosis, which was discussed both by Dr. Sham and Dr. Shailesh. And another important thing is the alkaline phosphatase, more than 100 units. So this is actually looking at various regimes, and this is data from over 1,080 patients. And they've said that if there are no poor prognostic factors, the survival can be as high as 11.8 months. But once you have the poor prognostic factors coming in, if they're 1 to 2, the survival drops to 7.4. And if it is more than 2, it's a dismal 4.1 months, very close to what I showed you earlier of the best supportive care. And this data was published in 2004. Now, this is just to sort of summarize all the chemotherapy agents that we have, starting with the fluoropyrimidines. We have the longest fluoropyrimidine, that is the IV-5FU, followed by capecitabine, and the recent addition is S1. We have the platinums, oxaliplatinum versus cisplatin has always been a debate, and I'll show you some evidence to that. In the taxanes, we have docetaxel and paclitaxel, and in the topoisomerase inhibitors, irinotecan, which is quite extensively used in Japan, but not in other parts of the world. And in anthracyclines, most of the stomach studies have used epirubicin. So this is actually an analysis looking at chemotherapy combination versus single agents. And this was published in JCO in 2000. And these are several studies that have been put according to 6,000 patients in each arm. Again, all showing you that the advantage is with combination chemotherapy as compared to single agent. Now, this is the REAL-2 study, which actually looked at 4 different drug combinations. And this was presented and published by Dr. Cunningham in NEJM in 2008. And here there were over 1,000 patients. And this is the randomization that you can see, the 4 arms. And what came out was that they were very, very similar. But again, studies which were comparing, looking at capecitabine versus 5FU. And these 2 studies actually showed that the capecitabine was non-inferior to 5FU. So many people have actually shifted to the use of capecitabine in place of 5FU because of the problems of administering 5FU and the need for hospitalization. So coming to the role of platinums, again, this is several studies put across together showing you that having a platinum is definitely better than not having a platinum in your chemotherapy regimes. And that is important for us now. So this is, like I mentioned, looking at oxaliplatin versus cisplatinum. And you can see that this is data again from the REAL-2 study showing you that oxaliplatinum or cisplatinum, the responses and the outcomes were very, very similar. And you can see that there were almost 500 patients, and the median survival, the 1 year survival and 2 year survivals are very similar. So we do understand that in many stomach cancer patients, giving cisplatin with hydration may be difficult, and therefore oxaliplatin can be used to replace cisplatin. Now, the role of docetaxel came out was from this TAX 325 study, which had 445 patients. And these are the two arms, docetaxel, cisplatin, and 5-FU given every 3 weeks versus cisplatin, 5-FU given as shown here. And the primary endpoint was time to progression. And this again was published by Dr. Van Kitsum in JCO in 2006. And this is the data for you. Time to progression, as you can see, DCF is faring far better than when in the arm that did not have docetaxel. And you can see up to 24 months, there is a follow-up, and DCF is definitely much better with a significant p-value of 0.0004. Now coming to the secondary endpoint, which was overall survival, and this is the final analysis. Again, showing you that there was an overall survival advantage when docetaxel was used, and the risk reduction was as good as 23%. So definitely there is an advantage of using docetaxel. Now this is the other study called the GATE study, which has used modified docetaxel regimes. And as you can see here, this study had a part 1 and part 2, and the combinations I've shown you here. This is docetaxel, oxaliplatin, 5-FU, capecitabine, leucovorin, continuous infusion, 5-FU, and they've been used in different combinations, and all that have been listed here. And what was done here was the part 1 had 2 levels. They had 10 patients in each arm, and then they proceeded to the level 2 after an IDMC review. Again, they had 10 patients in each arm, and then a further IDMC review. And then they went into the part 2, where there were 70 patients in each arm. And the final analysis were 240 patients, 210 from part 2 and 30 patients from part 1. So the overall survival, as you can see here, was the best with the TEF arm and the least with the TE arm. And this is the other study which looked at FOLFIRI versus ECX in the first line, because again, they're looking at varying toxicities and to see how best you can avoid toxicity for these group of patients who are sick by the sheer presence of the disease bulk. And they showed that the ECX and FOLFIRI were very, very similar in terms of outcome, but the toxicity of FOLFIRI was much less. So this is looking at a meta-analysis of the role of anthracyclines. Again, to show you that adding an anthracycline seemed to be better than not having an anthracycline. And this was published in Gastric in 2009. Now, this is some data from our own institute where I was for quite some time, as Dr. Bhuvan told you. And this is over a period of 5 years. And we have shown here that this is a collection of all the patients that we had. And the genes, this is just to tell you our real world experience. And this was the other study that we published in 2017, again comparing docetaxel-based regime versus anthracycline-based regime, because till this point of time, ECF was very popular till docetaxel came in. And what we showed was in each arm we had about 30 patients, and what we showed was the outcomes in terms of progression-free survival or overall survival was better with the addition of docetaxel, but again with increased toxicity. But as medical oncologists, we are well used to managing toxicity. So if you do have an overall survival advantage, then it is worthwhile this much of toxicity being managed. So this brings us to the treatment algorithm that we have today. And this is based primarily on the ECOG performance status. If the performance status is poor, then we don't want to give them the toxicity of our chemotherapy agents. So they would go in for best supportive care. And if it is better performance status today, we have a very important marker of looking at HER2 because we do have a targeted agent there. And based on that, we combine the chemotherapy either with trastuzumab or not. And this is going to be evolving very dynamically, as I will show you in the subsequent slides, because we need to keep ourselves updated, and that's important. So that is what I was telling you about, because precision medicine, like in other fields, has come in very rapidly into gastric cancer. And this was just published in 2019 in the World Journal of Gastrointestinal Oncology, showing you how we are looking at different parts of stomach as why we should practice precision medicine. Because till now we were clubbing the stomach as just one organ, and this is summarizing why each one of the part of the stomach is so different, and we need to look at it differently. So we are again now looking at MSI high or stable, as Dr. Sham mentioned, and based on this, we will be doing further management for these patients, and this is what is envisaged for the future. So we spoke about MSI high or low, and this is just to tell you that we have checkpoint inhibitors approved, and as you can see here, most of them are for second line, but again for TMB high, which is a tissue agnostic marker that is coming now, we have the role of these immune checkpoint inhibitors in the first line itself. So this is just to tell you about what molecular markers we're looking at in gastric cancer, because what I've told you till now is just chemotherapy, but is going to be rapidly changing in the future. And these are some studies which are actually looking at these checkpoint inhibitors in the first line. And I've just put the summary slides because this is not the mandate for my talk. And these are all going to come in very, very rapidly. So what I have told you till now may be very redundant very, very soon. So this, to almost summarize, I've adopted from the ESMO open paper, which says how I treat gastric cancer. And these are the first line studies, some of which I've already shared with you and discussed. These are the other studies which, for shortage of time, I have not discussed in length. And this is a summary slide for all those. Again, showing you that using chemotherapy definitely has benefit in terms of overall survival and progression-free survival. And docetaxel is an important addition. And of course, S1 is coming in now. So the addition of epirubicin to chemotherapy doublet has not definitely demonstrated overall survival, but has slightly increased toxicity. In contrast, the addition of docetaxel has offered small benefit, and the toxicity, of course, is high, but we do believe that this can be taken care of. The latter fact towards the fact that the taxanes can be now used in second line makes us not try and use this in the first line setting, because there is rapid data that has come in with the use of ramucirumab with the paclitaxel in the second line. And therefore, now we are tending not to use taxanes in the first line because we need to keep them reserved for the second line. And we have today understood that the more number of lines your patient can take, the outcomes are definitely better. So the original DCF regime, or better, the analogous less toxic plot regime, which Dr. Sham discussed earlier, should be considered in young patients for quick response. And we can always reserve the taxanes for the second line with many other drugs. But as I showed you, there's a lot of change happening in personalized medicine, and we will be seeing newer agents, newer combinations, and based on the place where the tumor is present in the region of the stomach. So with that, I think I will stop and thank you very much.